So here's one for you, Gibran. Should we have legalized cannabis?
Is my mic on? Okay. And so there are two parts of that answer for me. As far as legalization at a societal level, criminalization of substance use prevents people who need help from seeking help. They're not able to go into the hospital or the ER and say that I need help. And so from that perspective, legalization has been great. In addition to that, it was often already the most marginalized that would be further marginalized by criminalization of substance use. Too many black and brown people were incarcerated because of cannabis. And so that, again, makes legalization the right thing to do. But legalization also needs to be done in the right way, based in evidence. And I think a beautiful example of this is actually your province of Quebec getting something right when it comes to edibles compared to the rest of the country. So one thing we know is, compared to the rest of the country, which allowed gummy bears and edibles to look like all sorts of candy, in Quebec, only things that would not be attractive to children were allowed. So rutabaga flavored edibles, dates infused with cannabis oil, for example.
Broccoli.
Right? Broccoli. So, the really things that even adults wouldn't find attractive, right? So they only legalized those, whereas everything was fair game in the other provinces. And as a result, there was a doubling of the cases of pediatric emergency cannabis poisoning in all of the other provinces compared to Quebec. And so smart policy that's based in evidence works. But we didn't get that at a federal level. And so that's where hopefully 6 years later, we can revisit it and maybe put some guardrails, or what are the gutter guards on when you go bowling, on legalization.
Very interesting. Very clear worked example. Yelena. Yelena, I was struck in your presentation that there should be very, very strong cultural differences. In some cultures, it's extremely rude to make eye contact with other people. So have you explored the differences between different cultures?
So that's an excellent question. Is my microphone working? Yes. And up until very recently, we were not able to address this question because these fancy eyeglasses were in fact not available. And so we were not able to study, different cultures conversing freely in like a typical natural conversation. Some of the studies that have been done just very recently, again, have quite surprising answers. In fact, it has been theorized and it has been observed that perhaps people coming from East Asian cultures will not look at eyes very much, or would look at eyes less so than people coming from Western cultures. However, when we measure that using this kind of equipment, it doesn't seem to hold up. And so there's some very interesting questions on the horizon to get at these cultural differences, as well as other situational differences that perhaps might change this pattern, but they might not. So, yeah, interesting question. I don't know the answer.
Nobody stare at...
Where's the question?
There's a question there.
Again, regarding cannabis, I was wondering if all the research was really around THC and if it applies as well to CBT.
And I think that's a very important question. THC is not the same as CBD, and CBD is not the same as THC. These are the two most prominent phytocannabinoids in the cannabis plant that we know of, and out of 100 others. THC acts as an agonist at those cannabinoid receptors that I talked about. And so it's the primary psychoactive component of the cannabis plant. CBD, on the other hand, does not seem to act directly on those cannabinoid receptors, and has, in fact, I call it the pig's breakfast of pharmacology. It kind of acts on everything in the brain and does a little bit of everything. And so they cannot be painted with the same brush. CBD, in fact, may have some medicinal properties as well, and while it remains to be proven that, in a double-blind, placebo-controlled, randomized trial that they have those abilities, it is something that is very distinct from THC. And so I think both should not be taken with the same brush. But as far as the developing brain is concerned, some of our work and others shows that CBD may have effects of its own on the developing brain. So it's not innocuous in terms of its effects on the developing brain.
In the spirit of the cannabis talk, I have a half-baked question, but it's a question for Dr. Yelena Vistic. Sorry, I had to.
I'm a dad, so I love dad jokes.
It's really just a question about, is there a critical period for visual social communication? And then how do pandemic babies, how will they turn out? And also, does eye contact and conversation differ based on the age group? So are younger people, especially since they're on their phones all the time, and I think I'm part of that group as well. Like, do we look around because we're so used to not looking at other people? So those are the questions.
So thank you. These are all excellent questions, and the ones we don't have answers to. Unfortunately, I'm sorry, that's how science is. There's a lot of interesting questions, but I can speak to some of that. As we have not yet been able to, these are also very recent, so these are publications from last year. There have been some studies in the pandemic looking at children who have been in conditions where they wore face masks. But it's really unclear and difficult to understand, how they might differ if they, say, hadn't been in those conditions. So these are very, very important questions to study. And now we have the method, we have the ways to assess this. And then also we have some benchmark to compare, say, the prevalence of looking in different age populations in older, say, adults or younger adults, because these kinds of numbers are fairly surprising. They were surprising to us as well. And we often thought as scientists that people look at eyes and faces predominantly during interactions, but that does not seem to be the case. So these are excellent questions, some that I'm also interested in pursuing. Yes. And thank you for asking them.
There's a question there in the middle.
Thank you guys all for your talks. I had a question for Professor Ristic. So I was wondering how you might account for the fact that these eye tracker devices are not really natural. Like, what if, for example, the percentage is much lower for looking eye to eye because people are wearing these odd devices on their faces?
Yes, so thank you for that question. This is, of course, as researchers, we always have to sort of weigh the pros and cons of our methodologies. So prior to these eyeglasses, we in fact did not even have a capability to understand where people look in real life interactions. So it's just they're able to sit like this and interact. And how we measure the prevalence of or even interest where people look in scenes or faces is by sitting them in front of the computer and putting pictures, and then we would measure how often people look at certain parts. It turns out, actually, that people look very differently to pictures versus real agents. And why that is because agents and humans can reciprocate back. And we are very sensitive to this information of reciprocity from others. So even though we see something in, say, a picture, that picture does not reciprocate back to us. But something that we see in a real human, they may not reciprocate, but they have a potential to. And that's where this critical sort of difference is in understanding behaviors in real life interactions. Now, you're asking about the eye trackers. yes, it's potentially the case. We could, for example, film the interaction using, say, cameras that are on the ceiling, but we would not have a precision to understand and to see eye-to-eye contact versus, say, eye-to-mouth looking. So it's a bit of a trade-off there, but at least we have elevated our understanding of conversational eye contact in natural interactions to some extent.
So, Adrienne, this is maybe a bit of science fiction, but there's a thing called the telomere, which is kind of a sheath on the end of your DNA, which stops the DNA from fraying at the edges. And people have said that is a biological clock that predicts age. Could you talk a little bit about, is that real?
The telomere.
The telomere story.
Yeah, the telomere. Well, at first it was a super exciting. There was this belief that the telomere was everything. As we have progressed in our understanding of the field, and as I mentioned, we haven't finished at all understanding this space. The telomere is related, and we have seen that longer telomeres, especially this experience is starting in this kind of blue lagoons across the world. In Greece and Italy, there was one in California, that there's kind of blue spots across the world. And those people, there was the idea that, well, they might be doing something different. They might have some kind of genetic marker, and they started to study their DNA, and that's where like the telomere hypothesis started. Now we know that it explains part of that longevity in those populations, but it's not the whole story, right? You might have longer telomeres, and still you might not have that kind of trajectory.
It's never going to be simple, is it?
No, we don't have like the magic silver bullet, and we solve it all.
The question here.
Hi, very interesting, by the way. I was just wondering, all these new discoveries, of the research you guys are doing, how does it translate into actual patient care, new treatments, new techniques, prognostic, for example? And the second piece, if we have a unique biology and neurobiology, what's the effectiveness of treatment if my biology is unique versus somebody else, right? And how do we do that?
Adrienne, I think personalized medicine.
Yeah, it touches a bit of what we talked before. So, as I mentioned, we are all unique. And of course, this goes a bit on, for example, the treatment piece goes a bit on how the medicines are created and developed. They're not necessarily targeting you specifically, individually, but they're made for the average kind of responders. There's kind of a bell curve, and it's targeting the largest percent of the population. Even your standard Tylenol is made for this kind of, about 60, 80% of the population, and you might take a Tylenol and it doesn't work for you necessarily, and you're in that little 10%. So that's the way that we're functioning at the moment. The idea is that as we personalize this kind of forecasting, we first personalize the kind of drug development, it starts to become a bit more, less for the general population, more for what you need specifically. I think we're still far from that. There are some medications in cardiovascular disease, for example, that target specific genetic mutations, but those are like the fringe, is not really the way that we operate at the moment. So we're getting better. We are knowing much better about you, your biology, your underlying risk factors, but still, this is something that it's still in the building. And even, for example, the personalized kind of treatment and prognostic is not something that, if you throw it into the real world, you might encounter enormous different variability. So the prognostic might have a bias. As you can see from some of the, even like the more commercial kind of material stuff, it's biased into certain ways because we don't know when we are training it, it's very different from how we are developing this or throwing it into the real world. So there are some limitations, and in health, we want to be very cautious on how is this deployed and it's not affecting or targeting or harming people, but rather helping them.
Yeah, and another way to phrase that is that doctors in the past had to put people in boxes. And they had 30 people in the waiting room. They get somebody in there for 5 minutes. They give them a treatment which is suitable for the group. Well, the analogy that I gave you at the beginning of the Star Trek tricorder, the whole point of that is you have all of this individual's information, which means that you can customize the intervention to that individual. I said, we're not there yet, 20, 30, 40 years from that point. But that's what this whole HBHL is intended to do, customize the characterization of each individual and each intervention for that individual. Question?
Yeah. Alan, could I just add something for the first question? I think events like this and podcasts like the Brain Canada's podcast and us as researchers and investigators communicating with the public, but also policymakers and legislators and politicians is also really important. And that's where that translation of the neuroscientific finding to the public can happen. And I think I'm grateful that all of you came, and hopefully all of you can serve as ambassadors. What you learned today, hopefully then you can communicate that to one person and they can communicate to two more. And then we can turn back the tide of misinformation that is rampant in today's world.
There was a question here somebody had? Okay, there's one at the back. If we can get a microphone to the lady back there.
There's four.
Okay, there's one here, and then we'll go to that lady over there.
So I'm addressing this to Professor Ristic, and based on what you were just saying to the previous question asker, considering we went through several years of COVID where most meetings ended up online and people using Zoom and not being face-to-face for a great number of years. Have you studied at all the difference in how people communicate now versus prior? I mean, and I guess I'm addressing that mostly to people of a certain age who, myself, for example, who used to do all meetings only in person and then was forced to do all meetings only on a screen. And now, the world has basically stayed hybrid. That's one question. The second question is, have you sort of looked at eye contact in other primates? I work with primates, large primates in Borneo, and when you see how they communicate through mostly their eyes and all, forms of tactile communication, it makes such a difference what they absorb and what we as humans absorb as well. So I'm curious if you've done any studies in as how human eye contact and primate eye contact come together.
Thank you for those questions. I will address your second question first. I have not looked at the comparative studies, but I would not be surprised that we have a lot of shared, this nonverbal communication system that I believe is very, in many ways primitive, but in other ways very sophisticated, that allows us to communicate to one another without spoken language. There are studies in primates, of course, that they use eye gaze very similarly as people do. They use gestures, social signals similarly as humans do. So I have not done any studies. There haven't been studies, but it would be interesting, of course, to see if there's convergence and then divergence. With your question about COVID, it's interesting. We've tried in my lab. It's kind of difficult to study it from the design aspect because we were all people before COVID happened. So in research sense, it's difficult to account for those differences, So here's a couple of ways that we've addressed this question. First, we studied clear occluders. So not opaque masks, but masks that are transparent and that you could see the face through. And this is kind of a conundrum that we found, is that while we can eliminate most of the social communicative differences or difficulties, not all of them go away. And specifically, sharing of emotions and empathic responses still remain with this barrier, which we're now investigating why this is true, because we have restored most of the visual input to the face. Another possibility that we have studied is visual expertise. And how does, when someone develops expertise for communicating under occluded conditions, is that different? And so doctors, people spending a lot of time in these conditions, like working in mass conditions, may have different abilities. And I'll give you a preview. We just recently conducted a study that we'll present shortly, and the answer to that question is no. There's not very different behavior for people who have a lot of experience in mass conditions versus the ones who don't, which points to some very, very fundamental mechanisms that are being studied.
Okay, we'll take 2 more questions. Lady down here and very patient lady at the back who's been waiting. So we'll get the microphone back to you.
Yeah, about eye contact again. I was wondering, do you think I'm here?
Oh, yes. Hi, sorry.
Do you think in different relationships the rate could be higher? For example, mother, child, or lovers?
So this is something that we're also investigating. It could be the nature of the task. So what we ask our participants to do is what it's called a survival task. And so here we tell them, you're stranded on either a desert island or in like a winter scenario on like a mountain. And here's a list of 12 items. You need to agree on what you need for survival. And so it's a collaborative task. So we thought that maybe when people try to know one another, they would maybe, talk more to, like, look more at their eyes. We haven't done that study yet, but the study that we have looked at is looking at competition. So now we tell our participants, you're competing for the highest ranked object just for survival. And newsflash is that the data stay the same. So it's possible that there are differences in situational differences. We have just not been able to see the dramatic differences that one would intuitively expect.
Question at the back.
It's for Dr. Kalina. The research you're talking about, how does this translate into, let's say it was my dad at 85 and his 2 of his siblings that had dementia versus my aunt and a cousin at 65? How does this translate into the research of how do we import and how close is that to us?
So thank you for your question. You're saying basically that you had 2 different family members that had dementia at different ages, right?
Very different ages.
Yes. But so first of all, this kind of prognostic tools exist, and in a control setting that is in clinical trials, they work very well. So if, for example, if your family members would be in a clinical trial, this forecast can actually tell you where more or less they're going to go in a specific window of time. And of course, the progression into dementia is a continuum. There's different stages. So before you arrive to dementia, there's some certain decline that you can probably notice. And there's a pre-symptomatic phase where you personally don't feel or have symptoms related to that condition. So you're talking about familiar risk. So there's 2 different family members. There's a genetic risk that probably is carrying out. And then those 2 family members might have different profiles, right? They might have different life experiences, even though I was talking about the example of twins, that they evolve very differently. So inside the same family, there might be certain family members that inherited more or a higher risk. And then there's the lifestyle that they might be taking, and environment, pollution I talked about. So there's so much that affects each of those individual lives. Even in very close families, some of them might be affected, some might don't. But still, knowing that there's a risk, we can involve a prognostic element. And fortunately, at one point, we will be in the possibility of taking that from a clinical trial into the clinic, and where a neurologist or a family physician would have the tools to implement that into, let's say, an annual checkup, instead of just doing a simple cognitive test, would allow to include all of the others, the genetics, the blood biomarkers, all of that into a pool and give you a prognostic of where you're going to go in the next year, in the next 2 years.
Thank
I'll
you,
just make
because
a
that really
comment
interests
which
me.
I think is somewhat relevant to the question. Within HBHL, some of our researchers have been studying the buildup of the toxic proteins for amyloid and tau. These things are thought to be the cause of dementia. Turns out the buildup of these toxic proteins is not a result of a buildup, an oversynthesis. It's actually a consequence of underclearance by your so-called glymphatic system, which is related to your blood vascular health. So if you're designing a drug to interfere with oversynthesis, you're missing the point. It's not oversynthesis, it's underclearance. And so everything your mother and father told you about eating right, exercise, look after your neurovascular health has direct consequences for your mental health. So to answer your question, it could be just genes or it could be environment and lifestyle. Did they look after themselves? Did they exercise? Helps their body and that helps their brain.
So if I may add, in the clearance part, so something very interesting is that the clearance that happens in the lymphatic system happens usually at the highest in 2 moments during our day. When sleep, there's a period during sleep where the clearance of these proteins is the highest. And then there's another one, which is physical activity. When you're exercising, you're kind of pushing those proteins out of your brain. So those kind of modified risk factors, and as Alan was saying, like what your mother told you to exercise, like go to bed, sleep, that happens way before we're, at an age where, after midlife. So younger, starts to accumulate, but also doesn't clear well. All of this accumulates, and that's later life, we kind of pay the price for that. So
it's not rocket science. Look after your body; it'll look after you. So at that point, I think we'll stop for now. Thank you very much to our speakers.